want to get a show of hands in the room, please. How many of you are with a health home? If you could raise your hand. How many of you are with housing? And how many of you are neither? Other. Good, good. So it's roughly almost half health homes, a little over half housing people, and then a smattering of others. So good. So this is really what health homes are about, right? It's bringing housing people and health home people together. So the health homes are not a home, is the first important thing to know about health homes for you who may not know. But instead, it's an entity that is formed by different organizations to coordinate the care of high users of Medicaid in New York State. So they're targeted with working with people who are as they said, one person said earlier, super users of Medicaid. And they they're responsible for coordinating that care to improve the outcomes for the individual and save money in overall, efficiency, so we're not spinning our wheels to get poor outcomes. When health homes were formed, and this was allowed under the Affordable Care Act, this is kind of how it's all trickling down. When health homes were formed, the State Department of Health, when they were creating the regulations, the definition of health homes said, health homes must work with supportive housing providers. And in theory, everybody said, this is a great thing on all sides of the fence. Everybody said, this is a really great thing. But then, there are pros and cons to this, I think, the state did not detail what that meant. So the how this happened was left to all of us. So what we're hoping today we can do is talk about the how it's happening. Some people have been trying it for quite a while. Some of them are newer to this adventure, and we, CSH, have been involved in a lot of discussions, and so there's many familiar faces here of work groups and planning groups and discussions and all kinds of stuff of people talking about what this means, and as we figure this out together. So that's where I'll leave us with kind of the background, and we'll first turn to Shawna. And again, they'll give a little bit of background on who they are and why they're here, and then we're going to get into best practices and how people have gone about integrating health homes and housing.
So to progress the slides. There we go. Hi, everyone. Thank you so much for such great attendance. I hope we're going to have lots of conversation because we only came with 3 slides. Okay, I'm going to talk a little bit about health homes of upstate New York. First off, I'm from an organization called Onondaga Case Management. And historically, Onondaga Case Management is a behavioral health, mental health provider. We formerly were, our primary service was OMH, TCM, care management, the ICMs and the SCMs. You out there? Mm-hmm. Yeah, right? Back then. And we have a behavioral health OMH clinic, we have children youth services, vocational services, we have a HUD care management, forensic care management. That's what we do and did and continue to do. So when health homes came out, we clearly had a vested interest as a soon-to-be converting agency to figure out what this whole health home thing was about. And as we learned more and more about it, we recognized that we had to be at the table. We knew that care management to support these individuals was critical, and we wanted to make sure that our voice was heard in this. So our history as a behavioral health provider is in the community, and so we've had really strong relationships with the OASIS clinics, the OMH clinics, the housing providers, You know, we show up at social services, they wave, we know each other. So we were really closely connected to the community. And so when we were awarded as a lead health home, we recognized that we already have professional care managers in the community. And so our hub, meaning part of Honey, we decided that as a health home, the first thing we were going to do is we were going to contract with those professional care management agencies in all of our counties. So our friends at ACR Health are here. They're our converting COBRA provider in many of our counties. And so each county that our health home covers, we contracted with the converting OMH-TCM provider, so those care managers who are providing services to the people with serious and persistent mental illness, and the COBRA providers, those care managers who are providing services to people with the diagnoses of AIDS and HIV. In our neck of the woods, we used to have a MATS program, which is OASIS. We don't any longer. We had a CIDP program for a while. We don't have that any longer. So all we had was COBRA and the OMH-TCM. One of the challenges for us as not only a health home provider, but as a behavioral health care management agency and converting agencies was we had these great relationships with other behavioral health providers, but we were challenged around our partnerships with the physical health providers, with the hospitals, with the FQHCs, the health centers, and the larger practice groups. So we took the relationship we had with the other behavioral health agencies and started to have conversations as a health home and as a care management agency with our hospitals. I travel to all of the counties and have met with every hospital and have them signed up in our health home network of providers. I've met with all of our FQHCs. And what we're doing with this relationship is really starting to bring those providers to the table to understand the health home is about integration and collaboration and coordination of care. A lot of times, our behavioral health partners are more able to come to the table and have dialogues around the individuals that we're trying to serve. It has been a little bit of a bumpy road with some of our physical health providers, but we've developed some amazing relationships. Pointed out in this slide, Upstate is one of our large hospitals in the area. I'm housed in Syracuse, by the way. I don't know if I said that. And so we early on started a collaboration with them, and we have a number of projects going on, including looking at the Disrupt project, which I'm sure I'm seeing noddings of heads. So, you know, that project in itself has such potential for growth of both health homes, but more importantly, this collaboration of providers to support the individuals that we're talking about. So ultimately, we were awarded. We started these relationships, and we're going to talk more about our relationship, Onondaga Case Management and CNY Service as this housing support system. But what I would also just share is that early on, we recognized as a health home that thinking about how care managers function and where they function out of, we had to be creative around. We're not having 12 clients on a caseload. We're not having 20 clients on a caseload. And we're also not committed to the 2s and 4s, for those of you ICM and SEM providers know what I'm talking about. We weren't required to have certain numbers of visits, but we were required to expand our scope of supporting individuals. So early on, we knew that we needed to start thinking about moving our care managers to where the individuals we're serving are, as opposed to having them come, driving there, et cetera, et cetera. So we'll talk more about that, but so that's Onondaga Case Management, Health Homes of Upstate New York.
Shawna and I are piggybacking off of one another. Go ahead. Because of our close relationship of working well together. So it made sense that Shawna give you a little overview about the health home. I give you a little overview about the housing and what we do. I'm guessing that what we do isn't very much different than you do as housing providers. But then we can get into how those overlaps and how those collaborations work. So I'm from Central New York Services. It's a large upstate agency in both Onondaga and Oneida counties. So we are based in Syracuse, but we also have a lot of services in Utica as well. We've been around for over 20 years, providing multi-services around behavioral health care. So not only do we do housing and residential services, but we also provide a lot of forensic services, working closely with jail systems, probation departments, and court systems. And then we also provide outpatient services. We have a few others that come along the way as well, like financial management, all of that. All that being said is that we really, as an agency, were developed around trying to meet all of the needs of the individuals, not trying to be exclusive or hold to ourselves, but with the concept that we're really trying to give as much resources available to the community. We were also built on the mission, on the fact that we are there to serve the most underserved and at-risk people in the community. That's an important concept to us as an agency in terms of who we are, but also in terms of who we're working with. Because when we're talking about an MRT population or a health home population, really we're talking about the most difficult people to serve, because those are the people that are showing up in the ERs time and time again, or have been housed but lost their housing time and time again, or whatever the case may be. So we had already had a commitment to that population from a long time. Having been a community provider, along with Onondaga Case Management, gave us a basis or a foundation in relationships before health homes came about. We partnered together when Housing First became the model, and identifying that housing was critical need regardless of a person's stability. And so we stepped up to the plate and were really willing to work through the struggles of all of the different ways that we have to keep people housed, regardless of the behavioral problems, the substance abuse problems, the criminal activity that's going on, and developing ways around that. That is foundation as well to what we have to offer to a health home. And I say that in speaking to you as health home providers in terms of what you have to offer health homes as you try to partner with them. We've since done some other collaborations as an agency. We're working very closely with our state psychiatric center in the community and have really close collaborations there. All of this has led into our collaborations with the health home in and of itself. But then there came the concept of this is a brand new thing. What do you mean it's not a home? What is it really, and what is it? Who's it intended to serve? So as we as an agency struggled with what this was all about and how we fit into the picture, realizing that it's serving folks who are duly diagnosed in some way, manner, or form, whether it be mental health, substance abuse medical, whatever the case may be. We started looking at our own population and who we're serving and how our folks fit into that, and come to the realization that in our own setting, 75% of the folks in our supervised sites had chronic medical conditions of some sort or another. Of course, that wasn't news in and of itself. We've all heard about the fact that mental health population has a 25-year less lifespan than the normal population. We've seen the increase in medications that are being prescribed, the issues around incontinence and breathing difficulties, and all of the other associated health-related issues. And then as an agency, we also had a 50% or thereabouts rate of duly diagnosed mental health and substance abuse. So we really saw ourselves as already working with that population of individuals, for the most part, that are identified to be eligible for health homes. So we approached the health home about, we have this group of people ready and available and needing services. Oh, and by the way, with those 75% of healthcare issues, we're struggling trying to get them into regular physician's appointments, trying to get the physicians to actually spend time with them and get to know them and their problems, actually treat them like they're human beings as opposed to somebody to push out the door. And I'm not trying to badmouth the healthcare community, but we've all struggled through those difficulties of working through different systems. So we were able to come up with some different ways in order to do that. And this is where then some of the collaborations go on between Shawna and I and our organizations. So if we have all of these individuals, for example, who need to get to doctor's appointments and we're struggling with, and this is what the health home is all about, well, what can we do about that? Should we contract as an agency with the health home to provide care coordination services? Well, that's not historically what we've done. There are a lot of case management organizations in the area, so they had already connected with, but they come back with the offer to say, we can give you somebody to work with to provide those services for your folks. We were already working together. The difference in this case being is that for every 20 individuals that had a case manager / care coordinator, there were 20 different care coordinators to try to collaborate with. And of course, each one had a different approach, a different style, a different philosophy about what they were to do and serve. So by having one individual that we can coordinate with, we guarantee a certain population, a certain caseload for that individual. It gives us one person that we can work with, collaborate with for all the folks, and get to know each other better, work much more collaboratively together. So we come up with this idea. They're providing the staff person, we're providing the space and the caseload. And so far, if there are issues, we're right there at the table, we're working it out. If that care coordinator isn't available or there are problems there, we've got a supervisor to talk to directly and work out those issues around. So that's just one of the examples that we came together on. Housing. How big is your housing problem in case care coordination?
Right, I was just going to share, as a health home care management agency, we have a position dedicated to try to navigate the housing situation, because if you have any number of people on your caseload that are homeless or are calling you because they've just been evicted or will be evicted tomorrow, it then consumes your work. One of the ideal situations with this is that these folks are housed and we can work with the housing provider to sustain that housing, so that when the person starts to really struggle, for whatever reason that may be, we're in-house. And we know the care manager who's embedded knows what the expectations are and how to meet those expectations, and can help dialogue with both the individual as well as the housing staff to support that retention.
So we identified one of our big issues as being medical appointments and those kind of coordination of services. The health home comes back and identifies, well, one of their biggest issues is housing people who aren't already housed. So they come back to us saying, well, how can we work collaboratively on that issue? So they've got a dedicated housing specialist who is supposed to be a go-to person for the care coordinator, so that when a care coordinator is working with someone who all of a sudden loses their housing or is struggling, they go to that housing specialist who has a direct relationship with us, because we said, hey, we're one of your biggest housing providers, so why don't you come to our biweekly intake meetings and present any of the people that you have that you're struggling with. We'll see what we can do to solve that problem. And of the number of services we have, we can find the best fit and have those direct relationships so that we get that referral started immediately and get that person in that direction of housing as quickly as possible, so that the rest of the work can go on with all of the other needs that are going on. The other portion of the slide here, and just another component of how we kind of collaborate together, and this is still kind of working itself out, because what we find is that while some things work for these folks and this works for these folks, every day there's a new problem, a new development of what somebody needs, you know. So like a supported housing program can provide a bed and a couch and the necessary kitchen supplies, but can't provide something else. Well, maybe they can, or find somebody else who can. So we come together on those kind of things. But we've put together some recent proposals with all of this new money that's coming, and talking about how are we working together toward this end. And many of us are HUD funded, have these 3 component goals to work on: housing stability, the self-determination, and the financial stability. Well, that works out kind of well, I think, that we're able to provide that housing stability. We can connect to an employment vocational benefits person, and the care coordinator can help make sure that the mental health, the physical health care, the substance abuse needs are getting taken care of. But that's not to say that it's rigidly divided either, because a lot of times it's us as the housing provider that's getting the phone call from the treatment provider saying we have a problem with this individual, or they're not showing up, or they came up dirty, or whatever it may be. If we get the call, then we of course notify the care coordinator and we work together, as opposed to saying, well, that's not my job, or that's not my role, or that's what you do. No, it's let's come together, problem solve, let's work it out, what's going on, we meet together, all of those kind of things. But those 3 components just laid it out in terms of one of the RFPs that we responded to most recently, and kind of the light bulb went on for me when I went, yeah, that's kind of how it's working anyways, in a way. And we didn't even know we had that roadmap already planned out. So I know that everybody else here has a lot of ideas. We're going to talk about a lot more ideas with the case studies, and I'll let somebody else.